Good morning, everybody. Okay. So I suppose what I'm going to try and do is give a little bit of an overview of the effects of the current system on trying to deal with unintended or crisis pregnancies in Ireland. So overall, women's healthcare experience in relation to unintended or crisis pregnancy falls far below Irish healthcare standards in other areas, or indeed international healthcare standards. And women's health and well-being is compromised by this current legal framework on abortion. Denial of abortion services within the state do this in the first place because a woman's life must be in danger in order for them to qualify for a termination. And then even in those cases where somebody is eligible for a termination, the Protection of Life During Pregnancy Act, as Jen said, puts sort of procedural barriers in place which make it difficult to decide who's eligible and to access it. So there is an unmet need for abortion services in Ireland. Women in Ireland experience pregnancies that are unintended or become a crisis due to a change in circumstances. The Irish abortion rate is unknown. At least 3,265 women had abortions in UK clinics last year, and an unknown elsewhere. In 2016, we had research presented by one online abortion provider saying that in the 3-year period from 2010 to 2012, they provided 1,600 abortion pill packages to the island of Ireland. So that's simply one online provider, so it can just demonstrate somewhat that the figure of 3,265 is probably an underestimate. So who are these women and girls? In our clinical practice, between the doctors and the counsellors in the IFPA, we hear from these women all of the time. They come from all walks of life, from every county in Ireland. The UK Department of Health statistics for 2016 said that of women seeking abortions, the vast majority are in their 20s or 30s. That's 85% in total. And almost half married or in civil partnerships. So maybe ideas people might have of young teenagers is not actually the true picture. The exclusion of abortion from healthcare is associated with weak systems which put women's health at risk. So why is this? Okay, because of the ban on abortion and then the limited introduction of the ability for women to travel and have a right to information about abortion, the Information Act came into being. And this set up a system whereby provision of information about abortion is not provided usually in medical health settings. It's provided in a separate system which is called the pregnancy counselling system. And whereas pregnancy counsellors offer a really excellent service of sitting with women and going through their issues and trying to help them to see what's best, to decide what's best for them, if a medical issue arises during that, the counsellor is not actually qualified or comfortable with dealing with it and may not have an obvious go-to person, because a lot of these counselling services are not even located within primary care settings per se. So at least in our clinic, if that happens, the counsellor can contact me and I can take over or intervene and we can do it together, but that isn't the general way that things work. So it's problematic for the woman because she's being passed from one service to another. It's problematic for the counsellor because they're out of their depth. And it's problematic if a doctor tries to take on that role, they may not have the time or the training for the in-depth counselling part of it, but also they may not feel comfortable giving information which essentially amounts to a referral to a clinic about which they know little in terms of what standards are applied there. It also prevents explicitly doctors from referring women to abortion clinics. So even if a woman has serious health issues, whereas you can give that woman her information, give her records and explain to her the importance of providing that if she goes somewhere, you cannot make a phone call and say, this woman needs to be seen, these are her medical problems, where is the best place for her to go, what procedure do you recommend for her? That isn't actually permitted. So you have this disconnect if you had any person who had a serious medical problem, and I'm not even suggesting in this case that the medical problem is necessarily even the reason for the abortion, but if they were going to go to another service and have a medical procedure, a general anaesthetic included, you would actually feel it was your responsibility to pass on that information, and that it was a lapse of duty to actually not ensure that that information was going to be received before the woman presented there. So you have this loss of continuity of care. The women frequently are going to access the services without any advice from their doctor. Their doctor is not going to get any feedback from where they have been. So everybody is left in the dark about what has been the experience. So these women are forced out of Ireland. Their decision is then made under more pressure. So an awful lot of the decision making for the woman is focused on, where do I get the money? Who's going to mind my kids? How do I get a note for work? And how do I do this quickly? So it's not, is this the best decision for me? It's all these other practical issues that come into the decision. A woman who's actually travelled and spent all that money and got to the UK, who then arrives in a clinic, and I've certainly had this story from women, who has second thoughts, who's not really sure if they want to go through with it, quite often does, because the option to go home and think about it for 3 days just simply isn't there for them. So they know that whatever decision they make that day, that's their final decision. They can't afford to come back to this again. Their choice of procedure is completely dictated by the fact that they're travelling from Ireland, because whereas worldwide in countries where abortion is legal, the trend has been about 80% of women now will have medical terminations, with 20% or less having surgical terminations. The exact opposite statistic applies to Irish women. Less than 20% of Irish women have medical abortions, with 80% opting for surgical procedures. And it's purely down to a practicality. A surgical procedure is over in one day. You go in the morning, you're out by lunchtime, you're on your flight in the morning, you're on another flight in the evening. You're not going to have the risk of miscarrying in the airport. If you have a medical procedure, you have to spend at least one overnight, and you risk arriving in the airport and having cramps and bleeding the whole way home. The normal, simple post-operative little bit of pain, bleeding, anxiety, feeling a little bit under the weather after an anaesthetic, which isn't a huge deal for most people, but it's experienced on trains, planes, taxis, buses. It's not actually in people's own homes. People obviously can't access follow-up with their provider, because that would involve another plane trip to go back. So that just doesn't happen. So in a lot of cases, if somebody has at least seen a counsellor in a setting where there's also a doctor before they go, they are likely to come back to that service. But if somebody has gone under their own steam or hasn't told any doctor, then if they feel they have a problem, they have this barrier to actually deciding, do I have to go and tell somebody this whole story now? The denial of abortion also causes delayed access. Women from Ireland are still having later terminations than those in the UK. And whereas this has improved hugely since the 70s and 80s, when it was known in the UK that the Irish women were the ones having the mid-trimester between 14 and 24-week abortions, but there's still a huge difference. So only less than 70% of Irish residents access services before 10 weeks, whereas over 80% of UK women will be accessing those same services before 10 weeks. And in some cases, this does amount to coercion, because for some women, the barriers are just insurmountable. So they end up, by default, continuing with pregnancies. They don't have the facility to get the money, particularly not maybe under the time pressure that they're under. They may just not have support. They may not have anybody to look after their children. They may have a disabled child already, and they simply can't get somebody to look after that child. If they are immigrants and they don't have papers yet, then it's almost impossible for them to leave the country. If they have really poor English, the simple thing of ringing up the clinic and understanding what the person on the other end is saying so that you can make your appointment may actually prevent you making an appointment in the first place. Disability and age are obviously going to be barriers to being able to travel independently, and something as simple as living really far away from an airport, which means that you now have 2 extra days accommodation to put in, can be the make or break for some women. Women are made to feel like criminals because all of this is done in such a clandestine way. You don't speak openly about it, you don't tell anybody, so people feel like criminals. People feel stigmatised and isolated. If you think about it, if you go and have your tonsils out, everybody asks you afterwards how you got on and how sore was it and how bad was it. Nobody talks about what your experience was like if you've had a termination. And access to abortion in Ireland, I think this is the worst part really, is that it's completely inequitable, that we are completely happy to say as long as you have money and backup you can have an abortion, and if you don't, then that's it, you can't. So it totally disproportionately affects disadvantaged women. So unsurprisingly, there has been a trend for women to seek to self-induce abortion so that they can save that money and get over some of those barriers. Criminal laws do not deter women from seeking abortions, and women from all walks of life are actually accessing medication to self-induce. And I mean, this isn't even just women who absolutely can't get the money together, it's women who are making a decision, do I actually prefer to get something delivered for a fraction of the cost that I can actually do in my own home without this need for going off on the plane and coming back in the evening? And a lot of women, if they are put in that position, will choose to do that. And I just think it's unacceptable that this kind of clandestine self-medication is the best option. The women know that if they're actually taking that medication in Ireland, they're breaking the law. They're afraid if anything goes wrong, are they going to end up being caught? And we wouldn't advocate treating any other condition in that way. We wouldn't say, if someone came in and said, I have a heart condition, I wouldn't say, well, why don't you go online and see what you can do? You know, it just would be ludicrous to suggest that you would do that. The main health risks, at least that there is, I suppose, a positive side, that abortion medication doesn't tend to cause serious harm in most situations. The main concern would be failure, that the procedure simply doesn't actually produce an abortion and that the woman doesn't fully recognise that. And this usually will be due to later gestation, so the woman is further along in the pregnancy than she thought. There may be bleeding, but the pregnancy may not completely come away. So she may not actually realise for several weeks that she's still pregnant. And there is a whole issue there as well, that abortion medication can cause fetal harm. So if a pregnancy is continuing, there is a slightly higher possibility of there being a problem. In some cases, there are places selling these drugs over the internet, and there's nothing in the drugs. It's a complete scam, and they know that they can do this because nobody is going to actually complain that they didn't get the right thing, because nobody is going to admit to having done this in the first place. If something does happen, if anything goes wrong, women are fearful of seeking help, and this definitely I've seen at first hand, where it's 3, 4, 5 days after a problem arises before they eventually come in. And in some of those cases, there's nothing wrong. All they actually needed was to be told that what they were experiencing was normal. And they have sat at home for 4 days, perhaps, worrying about something that they could have been reassured about really easily. In worse cases, you have somebody who comes in who's actually been bleeding for 3 days. And I mean, I haven't seen any serious complication, but certainly that's somebody who should have been seen 2 days earlier, and who would have been if they had been at home. In some cases, the providers do provide some online email support, but again, if something happens during the night, a woman is waiting until the next day to get a response from that. And we seem completely happy to absolutely not monitor these women's health outcomes at all, not to actually concern ourselves with what the standard is of care that they're receiving and what outcomes they might have or consequences. So the other part of the legal framework then is the Protection of Life During Pregnancy Act, which, as everybody probably knows, clarifies the circumstances in which abortion is legal in Ireland, which is when there is a real and substantial risk to the life of the pregnant woman, and sets out the system by which this legal entitlement can be established, including a review system. And the Medical Council guidelines have been updated to reflect this. So the reports available so far on the numbers of terminations carried out under this Act are presented there. So that's 2014 and 2015, and they're identical. So 26 in each year, 9 of which were emergencies, 14 from physical illness, and 3 related to suicide. So really low numbers. You can see, first of all, that there's very, very low numbers of women accessing the Act. The emergencies probably would have been conditions that were arising anyway, and abortions, if you want to call them endings of pregnancy at least, that were happening anyway because they would be acutely ill women in an obstetric setting. We don't know what the physical illnesses are that gave rise to the grounds for termination. And in each year there was one case that went through the review process to the end. In 2014, that case was then turned down. In 2015, the case that went for review was actually granted. So what are the difficulties with it? Well, I think Jen kind of put her finger on it when she said this wasn't actually designed as a clinical guide. This was a legislative process put in place to cover a really, really small entitlement. So access is the first problem. I mean, women don't know how to access it. Lots of women don't even know about it. And doctors don't know how to get a woman into that system quickly where she gets assessed. And this is obviously a really time-sensitive thing. In terms of guidelines, there are pages of guidelines on exactly what qualifications every person in the certifying process needs to be, how many people need to do each part, what they have to fill in. But in terms of how do you get that person assessed, there's literally one little paragraph, and the advice is get an urgent opinion of a consultant obstetrician, without any explanation as to how you're supposed to accomplish that. Everybody knows what the health system is like in Ireland. It's not a simple, straightforward thing to get an opinion of a consultant. Lack of clarity, as I said, we don't really know what medical conditions are going to be allowed and what ones aren't. We don't know what degree of risk to life is going to be considered enough risk to life. So when you can't give that kind of guidance to a woman, she's very unlikely to want to take the chance of going down that road. Her opinion is not taken into consideration in any serious way. So if somebody decides, whether it's the obstetrician and physician, obstetrician and psychiatrist, whatever the situation is, if somebody decides that there isn't sufficient risk to her life, then she just doesn't qualify for an abortion. And she can, if she wants, go through the review process. If they still don't agree, she doesn't get the abortion. So what might be a completely reasonable amount of risk for me might be a completely unacceptable level of risk for somebody else. And in everything else, we give the person that choice to make. We would say, this is the risk of the procedure, do you want it? We don't say, this is the risk of the procedure, but you have to have it one way or the other. That's the end. You know, and that's what we're doing in this situation. The review system, I think, is obviously difficult, since only one person in each year actually went through it. The review has to be in writing, so automatically women with poor English, women with poor literacy, women with severe mental health issues are going to be disadvantaged in actually completing the review process. If they're refused after that, they've now probably experienced 3 to 4 weeks delay at least, and they still haven't had a termination. And obviously the Protection of Life During Pregnancy Act doesn't actually apply to the majority of women who are seeking terminations at all. It's got nothing to do with them. So what women need really is some sort of health systems approach where access to abortion is integrated into the normal reproductive health system. Lots of organisations around with really, really good quality guidelines, FIGO, the RCOG, World Health Organization, so it's not like we'd be starting with a blank sheet. The WHO, I think this is interesting just to see where we actually stand on this. Their guidance says that the first thing in terms of crisis pregnancy is to reduce unintended pregnancy, ensure access to contraception and sexuality education. So we do have access to contraception in Ireland. There are still barriers, cost being one of them. We do have sexuality education, so at least we're going right on point one. Ensure timely access to quality assured affordable abortion services which meet the needs of disadvantaged women, definitely not. Avoid administrative or procedural barriers to access to services, definitely not. We have done nothing but put barriers in place. Respect women's reproductive health rights, dignity, autonomy and equality, absolutely not. So what we need to do is to prioritise access. Access to good quality services ends up reducing abortion rates, and the other speakers can actually demonstrate that more than I will. Evaluate how other countries have developed policy and implemented best practice, and in particular look at countries who have recently reformed abortion laws to see why they did the things they did and whether they apply to us. So in conclusion, I feel really strongly that the status quo is inequitable, it's unjust and it's unacceptable. Human rights expert monitoring bodies have all called for reform of Ireland's abortion laws, but we must be careful when we're reforming the law that we don't introduce new barriers and new problems. Ireland can't continue to accept this system. It's inherently weak and it's failing women. We need healthcare-based services without these unnecessary barriers, and to do that we must integrate abortion into our healthcare system in line with good healthcare practice, good international guidelines, and make it subject to proper monitoring and evaluation like every other aspect of the health service. Thank you.